Pediatrics cardiologist. A little bit of background about her. She went to medical school, her residency in pediatrics, as well as her fellowship in cardiology, all at Columbia. So her heart and soul is with Columbia. She's very credited and has so much to share with us about the congenital heart defects and the heart health of an AP patient. So let's learn about the heart now. We learned about the brain, right? Well, welcome, Shannon. Dr. Shannon.
Thank you so much for inviting me. It's really a pleasure to be here. And as everyone has said, we learn so much from you, and we'll try to teach you something in return. So I'm going to talk about congenital heart defects and heart health for 8P. And so just a little background. I'm first going to go through a little bit of the knowledge that we have about congenital heart disease in 8P patients. And then I'm going to go over sort of a very quick tutorial of normal cardiac anatomy and physiology, and then go through some of the specific types of congenital heart disease that we see most frequently in 8P. And just as sort of a disclaimer, congenital heart disease is a really varied topic, and each individual is going to be different. So I'm going to give you a broad overview to try to help with some understanding, but obviously for your individual child, if you need it, your pediatric cardiologist is going to provide you with the best information. And then I'm going to talk about some healthy heart recommendations at the end. So in general, the genetics of congenital heart disease in 8P is not completely understood. We still have a lot to learn. And in general, for all people who have congenital heart disease, the genetic basis of it is very complex. We know that changes in some genes can contribute to congenital heart disease, but we really don't understand the full spectrum of that. So we know that changes in one single gene can cause multiple different types of heart disease in different individuals. We also know that similar types of congenital heart disease, for example, an atrial septal defect, which I'm going to talk about later, can be caused by changes in multiple different genes in different people. And so we know that there's probably a complex interaction of genetic causes that lead to the development of congenital heart disease. And the heart develops really early, and so there's a lot of factors that are sort of involved. We do know in terms of 8P that there's a cluster of genes that are related to cardiac differentiation, which just means how the heart forms really, really early in the fetus. And we know that there's a cluster located on 8P of these genes that are important for normal heart development. But we know that not all patients with 8P and congenital heart disease have the same genes affected. So even within this rare condition, there's sort of differences in the genetic causes. So most of the information that's available in the literature for 8P is focused on 8P deletions, and we know that those are associated with a variety of different congenital heart diseases, and I'm going to go through some of these specific types a little later in the talk. The most common things are atrial and ventricular septal defects, which sort of on the spectrum of congenital heart disease are simpler lesions, but there are some rare cases with more complex types of congenital heart disease, like tetralogy of Fallot or hypoplastic left heart syndrome or truncus arteriosus. So thanks to all of you for contributing to the 8P database. We have some information about the patients in Project 8P and their cardiac diagnoses. So what we found so far with the data that we have is that a little over half of the individuals who contributed to the database have congenital heart disease. And some of these, some people have multiple different things. That's why these the percentages don't add up to 56. So just over half of patients had an atrial septal defect, about a third a ventricular septal defect, and pulmonary stenosis was the next most common thing. And then in a smaller percentage of people, they had bicuspid aortic valves, mitral regurgitation or prolapse, and patent ductus arteriosus. And in the Project 8P database, we found that about a third of patients with congenital heart disease had GATA4 deleted, and that's sort of the most well-studied gene on 8P related to heart development. But obviously, it's not the only thing playing a role here, because 2/3 of patients with congenital heart disease didn't have GATA4 affected. So I'm just going to sort of go through a quick tutorial of the normal development and sort of structure of the heart. I'm going to come around a little bit so I can point. So the heart has 4 chambers, 2 upper chambers that are called atria, which are collecting chambers, and 2 lower chambers called ventricles, which are the pumping chambers. So Blood that has already given off oxygen to tissues goes through your veins. That's the blue blood. And it all collects into two big veins, the inferior and superior vena cava, and comes into the right side of the heart. The blue blood goes from the right atrium into the right ventricle through a valve called the tricuspid valve. And then the right ventricle squeezes and pumps the blood out through the pulmonary artery, which is the big artery that takes the blood out to both of the lungs. In the lungs, the blood picks up oxygen, and then it comes back to the left side of the heart through pulmonary veins, into the left atrium, through another valve called the mitral valve, into the left ventricle. The left ventricle squeezes the blood out through the aorta, and the aorta is the big artery that takes the blood everywhere in the body, so up to the brain, down to the legs, and then that blood delivers oxygen to all of your organs and tissues, and then cycles back and does it again. So a couple important things to point out. There are valves in multiple areas here. So the tricuspid valve, the pulmonary valve is in between the right ventricle and the pulmonary artery. The mitral valve is on the left side, and the aortic valve is in between the left ventricle and the aorta. And the job of these valves is to open and let blood go forward and then close so blood doesn't come backward. So we want blood to just be continuously going in this loop in the right direction. And the other thing to point out is that there are walls that divide the right atrium and the left atrium, so that's called the atrial septum. And then there's another wall that divides the right ventricle and the left ventricle, and that's called the ventricular septum. And these are going to be important as we sort of talk about some of the common types of congenital heart disease. So what is congenital heart disease? It's basically any abnormality in the structure of the heart that's present at birth. And most of these alter the normal blood flow that I just described. And they can range from very simple things that may even resolve on their own without any intervention to very complex disorders that require multiple surgeries for palliation. Some lesions can, as I said, get better over time, and other lesions can progress or get worse over time. And so once someone is diagnosed with congenital heart disease, it's really important to be followed by a pediatric cardiologist who can monitor how these things are changing and decide if and when an intervention is needed. And congenital heart disease can be isolated. Some patients just have congenital heart disease and nothing else, but it can also be seen as part of a syndrome such as 8P. And as I mentioned, anyone with congenital heart disease requires evaluation and follow-up with a cardiologist. So how do we diagnose congenital heart disease? Two of the most common tests are an electrocardiogram. That's where they put stickers on your chest and sort of look at the electrical activity of the heart, which is what tells us about the heartbeat. And that can often give us a sense that something might be wrong and sort of give us a hint that there might be congenital heart disease. But the way that we really diagnose and follow congenital heart disease is with an echocardiogram, which is an ultrasound of the heart. And the ultrasound of the heart gives us a lot of information. It tells us about the structure of the heart, so how those chambers and vessels are formed. It allows us to see how the blood is flowing. Is it going in the right direction, or are some of the valves leaking backwards? And it tells us about how the heart is functioning or squeezing. So how is it actually pumping blood out to the body? And so we can get a lot of important information from this test. As I'm sure any of you who have children with congenital heart disease know, these tests can be a little bit long and difficult to sit through, but the reason for that is that we try to gather as much information as we can. So I'm just going to go through a couple of the lesions that we saw most commonly in the 8P database and just explain a little bit about what it is and sort of what we look for in each of these disorders in terms of whether we need to do something about it or not. So the first thing I'm going to talk about is an atrial septal defect. And basically what that means is a hole in the atrial septum, or that wall that divides the two upper chambers. And there's a wide range in size of these. They can be very small to very large, and there's multiple different locations within that wall that they can happen. And the location is important in terms of whether it's likely to close on its own or not. So overall, what happens if you have a hole in this wall is that some of this red blood, the blood that has oxygen from the left atrium, instead of all going to the left ventricle and out to the body, some of it goes across that hole to the right side of the heart where the pressures are lower. And so as a result, you get more blood going to the right atrium, the right ventricle, and the pulmonary arteries than you normally have. And so the right side of the heart can get dilated or enlarged, and there's extra blood that goes to the lungs. And over time, and in this case it's usually decades, if we didn't do anything about this, that extra blood going to the lungs can lead to problems like high pressures in the lungs or difficulty breathing. But usually for atrial septal defects, they don't cause any symptoms in children. It only becomes a problem if it's a large defect and we don't fix it and we leave it until late adulthood. If we decide that the defect is big enough that there's extra blood flow and we're worried the patient's going to develop problems eventually, we will decide to do something about it. And usually in patients with atrial septal defects, we try to repair them between age 2 and 5. It might be different depending on the size and symptoms in an individual patient, but that's sort of the ideal time we try to fix these. And there are 2 different ways that we can repair atrial septal defects. So the first is through a cardiac catheterization. That's basically where we use the big vein in the groin to put a catheter in, which is a long tube, and we use that normal path of the blood to put the catheter all the way up into the heart and into the right atrium, which is here, across that hole in the septum. And using that catheter, we can actually put a plug, a device in to block the hole. And so this doesn't require a big cardiac surgery. It's a minimally invasive procedure, and depending on where exactly the hole is and how big it is, this can be a very safe way to do this. If that's not possible because of the location or size of the lesion, we can do surgery to fix this, and that does require an open heart surgery where they can put a patch over the hole and sort of sew it in. And so there are multiple options for patients who need repair of this. The next thing I'm going to talk about is ventricular septal defects, so sort of a similar concept, except for in this case, the hole is in the wall between the 2 lower chambers, the ventricles. And so the left ventricle is the pumping chamber that pumps out to the body. So the pressure in that chamber is pretty high because it has to squeeze blood to your whole body. So because the pressure here is so high, you tend to get more blood flow that crosses through these holes than the holes in the atrium. And again, there's a wide variety of sizes, and they can be in multiple different locations within this wall. Because of the pressure and because there's extra blood flow, these defects can cause symptoms even in little babies. So with extra blood going from the left side to the right side, you're getting extra blood flow to the lungs, and often little babies with big holes will present with increased work of breathing. Sometimes they won't be gaining weight very well because their heart is working so hard to sort of pump this extra blood that it's using up a lot of calories. And so we can see symptoms even in young children with this. And so we have some ways of treating those symptoms before we do the repair. We can use diuretics, which are water pills, to try to get off some of that extra fluid and allow the child to breathe better. We can give them medications to help the squeeze of the heart, to sort of help it along so that it doesn't have to work so hard. And we can do things with maximizing calories to try to help the baby to gain weight before we do surgery. And sort of the decision of the exact timing of the surgery really depends on the symptoms and the size of the defect. If it's large, we generally try to do surgery for these before the child's 2 years. And we know that if we repair it before the child turns 2 years, they're unlikely to have long-term problems from having this hole open. So that's why we usually try to do it in that window if we can. But sometimes if it's sort of a medium-sized hole and we're not sure, maybe it'll close on its own, maybe it won't, we'll sort of watch it a little longer and then decide later whether to do surgery or not. Right now, the repair for ventricular septal defects is all surgical, so it requires an open heart surgery, although they are working on devices to be able to do a similar thing to atrial septal defects where we can close these in the cath lab. So the next most common thing that we saw in the Project AP database is pulmonary stenosis. So stenosis means blockage, and this is particularly blockage of the pulmonary valve, that valve between the right ventricle and the pulmonary arteries where the blood is trying to get out to the lungs. And so this happens because the valve doesn't quite form correctly, and so it doesn't open as well as it should. It sort of gets stuck. And so the blood has a harder time getting to the lung. And what happens is that your body and your heart is smart, and it recognizes that it needs to get more blood out. So the right ventricle squeezes harder to try to get that blood where it needs to go. And over time, that can cause this right ventricle to get thick. Just like any muscle that's working hard gets bigger, the heart is a muscle. And so if the right ventricle is squeezing hard, it gets thick. And that can cause more obstruction to the blood flow as this muscle sort of fills in this space. And then if you let this go for a very long time, that muscle can get tired. And you can get symptoms of heart failure if this isn't treated. But there's also, like everything I mentioned, a really wide range. So some patients have very mild pulmonary stenosis that we can just watch and we don't need to do anything about, and sometimes it's more severe and we need to intervene. So treatment of pulmonary stenosis, some patients may need a cardiac catheterization. Similar to what I was talking about with the atrial septal defect devices, we can do a catheterization where we put a tube up into the different chambers of the heart and we can actually directly measure the pressures, and that gives us more information about how severe the blockage to flow is. And sometimes we need that just for diagnosis, but we can also use a cardiac catheterization to treat pulmonary stenosis in some cases. And the timing depends on the degree of stenosis, findings on echocardiogram, and whether the patient has any symptoms. Ideally, we try to intervene on this before someone develops symptoms. So we want to sort of get in there before it causes real problems. And one of the treatments we can do is called a pulmonary balloon valvuloplasty. So again, we're putting a catheter up into the heart, and we put the catheter into the right atrium, the right ventricle, and across the pulmonary valve. And as you can see here, you sort of put a wire across the valve with a deflated balloon, and then we can actually inflate the balloon and sort of try to pop open the valve to allow it to open more and to allow the blood to flow more easily. If that doesn't work, or if that's not an option for whatever reason, there are surgical options to repair this as well, where we can either go in and try to fix the valve or to replace it with an artificial valve. Another type of valve problem, that we saw in the AP database is bicuspid aortic valve. So now we're talking about the valve between the left ventricle and the aorta. And this valve normally has 3 leaflets, as you can see here, 1, 2, 3. But in some people, this sort of area, this cleft in between these 2 leaflets is fused. And so you get just 2 leaflets. And the way that those leaflets work, the blood flow is abnormal as it goes through them. And so these patients can develop problems over time. However, this is really common, and we probably actually don't know how many people in the general population have this because we don't do echocardiograms in every person. And so some people have this and never develop a problem, and other people will. And so if you know that your child has this, it's something that needs to be followed by their cardiologist. So what are some of the problems that can happen with this? So it can lead to early calcification of the valve and stenosis. So all adults, if you look at sort of all 90-year-olds, they have some calcium on their heart valves and they have some blockage of flow. But in patients with bicuspid aortic valve, that tends to happen earlier than in everyone else. But only 1 in 50 people with a bicuspid aortic valve will have clinically significant stenosis by the time they're adolescents. Usually this is happening more in adulthood. We know that it can also, in addition to stenosis or blockage of flow, bicuspid aortic valve can be associated with dilation or enlargement of the ascending aorta, that vessel that comes right after it. And in those cases where the aorta gets big and is dilated, it's at risk of something called aortic dissection. And so if it's being dilated, that's something we watch very carefully. And then the third thing that can happen with bicuspid aortic valves is that people who have this are at increased risk of endocarditis, which is an infection of the heart valve itself. And so that's something we're also very careful about in patients who have this. In terms of the treatment, really it involves careful monitoring to see if you're developing stenosis or dilation. If the patient also has high blood pressure, we're very aggressive about treating that because that can worsen the dilation of the ascending aorta. And if they develop stenosis, we can do things similar to what I talked about in the pulmonary valve. We can do a balloon in the cath lab to try to open up that valve. We can do surgery to repair or replace the aortic valve. And we can, in some cases, even put in a new valve through a catheter procedure. If there's significant aortic dilation and we're worried about the risk of dissection in that patient, we will recommend replacement of the ascending aorta, which is, again, a surgical procedure. So in the AP database, those were sort of the things that we saw most commonly, and that's also what is most commonly reported in the literature in patients with AP. And in general, the things that I went over are also just the most common types of congenital heart disease in anyone that we see. But there are some patients who have more complex types of congenital heart disease, and I'm happy to answer questions about those in the breakout section later, but I'm not going to review all of the different types because that would take a very long time. So in terms of the actual genetics of congenital heart disease associated with 8P, as I said, it's not completely understood, but we do know some candidate genes. So GATA4 is the most well-studied gene on chromosome 8P that's related to congenital heart disease, and it's a cardiac transcription factor, which means that as the heart is developing, it sort of acts as a signal telling the heart how to develop normally. And so if it's missing or abnormal, it can lead to congenital heart disease. Mutations, so if we look at patients with congenital heart disease who don't have 8P, we see mutations in GATA4. So we know that that's definitely important for normal development of the heart. But thanks to some of the data you guys provided, as well as other things that are provided in the literature, we know that not everyone with a GATA4 deletion has congenital heart disease. So that can't be the only thing that's contributing. And as I mentioned, in our database, it was deleted or duplicated in about a third of the patients with congenital heart disease. There is some literature looking at two other genes, SOX7 and NEAL2, and basically what people have seen is if they're involved in the deletion, in addition to GATA4, those patients have more severe congenital heart disease than if you just have a GATA4 deletion. And then two other factors, so GATA4 and SOX7 and NEAL2 are sort of on the distal end, the far end of 8P, but we know that patients who have deletions or duplications on the proximal, the closer end of 8P, can also have congenital heart disease. And so there's been some research trying to figure out what's causing it in those patients, and there are two genes, NKX26 and NRG1, that have been shown in very small studies to also be related. All of this is to say that we still have a lot of work to do in sort of understanding this, and that in every patient there's probably a slightly different combination of factors that are contributing. So just in terms of what you can do if your child has 8P and congenital heart disease, as I mentioned, regular follow-up with your cardiologist is really important if congenital heart disease is present. If they had a really small hole that totally closed, it's possible your cardiologist will say, goodbye, you never need to come back again. But in most cases, if there's still something there, it's important to follow up. And if it's very minor, you may think, my child's doing great, I don't need to see the cardiologist, but it's important to come, even if they say come back in 2 or 3 years, just to check in, as some of these things can change over time. And then in general, for patients with congenital heart disease, it's important to do the normal things that promote healthy hearts as well. So we can fix a lot of the congenital heart disease, but we want your children's hearts to be good for decades and decades to come. And so trying as much as possible to do healthy diet and exercise as much as they are able to do and as is recommended by your physician is important. And just like all kids, we want them to do those things to sort of maintain their heart health. So thank you again for having me here, and I'll be at one of the breakout sessions later if there are questions. Although we have a couple minutes, I don't know.
Hold on, I have a mic.
At the beginning of your presentation, you briefly mentioned in my son's case, it's aortic regurgitation.
Yeah.
If you can talk about this further down, it's because there are not a lot of cases like this with 8P.
Yeah. Yeah, so as I mentioned, the job of the valves is to sort of open and let blood go through and then close and prevent leakage backwards. So I talked about stenosis, which are valve problems that prevent the normal opening and sort of block flow, but you're right that leakage is a problem. And basically what happens there is that the valve leaflets open okay, but when they close, they don't quite close all the way together, and so some blood can go backwards. And as a result, every time the heart squeezes, it has to squeeze a little extra blood forwards to sort of compensate for that. And so the heart can tolerate sort of minor, like small leakages, but if there's a lot of blood leaking, that can also require an intervention over time. And we did see in the 8P database, not specifically aortic regurgitation as frequently, but the mitral valve, the valve between the left atrium and the left ventricle, we did see some people say that there was leakage of that valve. So I think that's certainly something that we will learn more about. And we do know that in general, patients who have chromosomal abnormalities, not 8p specifically, that they tend to have problems with the valves. For some reason, valves are very sensitive in terms of how they develop, and so it's not surprising that that would be involved as well. Sure.
Yeah. Dr. mentioned, I think she alluded in her presentation this morning to AP patients as they got older being at risk of some cardiac, challenges.
Yeah.
Did you see any of that? And if we are one of those people who the cardiologist said, the hole has resolved, I don't ever have to see you again, is that true, or is there reason to be concerned as they get older?
Yeah, so I think if there's no congenital heart disease left, that's a good sign. And I think there's a lot we don't know as patients get older in terms of heart health, but again, sort of looking at some other disorders that have similar findings, we do know sometimes patients can have higher risk of getting things like coronary artery disease or high blood pressure later in life, maybe that everyone's at risk for, but maybe they're at slightly higher risk. And so I think regular screening with your physician to check blood pressure and to check lipids and all of those things are important. And if any of that is abnormal, I would certainly go back to a cardiologist. Mm-hmm.
My question was actually sort of related to that. We have a very young child with an 8p abnormality, and so it's been sort of a journey of like finding one thing out and then another thing out and another thing out. She's still only 6 months old, but I wonder if you could comment in terms of like at what age would you consider like a full presentation of what you might be dealing with congenital heart disease?
So in patients who have significant big holes or really bad stenosis, they have symptoms before 6 months of age, but there could be more minor things that wouldn't necessarily present. And I think it makes sense in any child who has sort of multiple medical issues going on to screen for heart problems. And so the first sort of step in that is actually all children, at least in the United States, before they're discharged home from the hospital, get an oxygen saturation screening. And so if that's normal, that sort of rules out some of the most severe types of congenital heart disease. And then your pediatrician listening to your child's heart, so if they hear a murmur or something abnormal, then certainly an echocardiogram. But I do think that it's reasonable to just request to see a cardiologist and get an echocardiogram at some point if you haven't, just to make sure that there's not some of these more minor problems. And generally, if that's the case, we don't like to do that very early on because there are, like in the first 2 months of life, because there are a lot of changes that happen in the heart over that time. The way that the heart works sort of in utero is different than once you're born. But once you're sort of past that 2-month phase, it can happen at any time. And so I would recommend just at least a one-time echocardiogram to check and make sure everything looks okay. And if that's the case, I would recommend you do it not when your child is a very active toddler, because it's easier to do the test if they're a little bit smaller and easier to keep on a table.
Still, life
yes.
still.
Can we say questions?
Yes. Yep.
Sorry, Gina.
Thank you so much, Dr. Nees. And you guys will all have an opportunity